So, very good evening to everyone who have joined for this meeting hosted by FPA Kerala chapter. This is the national part of FPA Clinical Meet series that we are conducting every week. And this October, again, we are having the opportunity for FPA Kerala chapter to host this clinical meet series. And I would like to welcome all the participants, teachers, and delegates who have joined from across the country to this meeting. So, we have chosen a very important topic in the family medicine perspective, that is comprehensive geriatric assessment. And to speak on this, we have Dr. Aishwarya V. Nambudiri. She is a consultant family medicine from Calicut. She is a graduate of Assisia Medical College and a postgraduate in PNB Family Medicine from Lutz Hospital, Kochi. And she has specialized in special interest fields like geriatrics and palliative care. Welcome, Dr. Aishwarya, to this meeting. And this meeting is being chaired by two of the eminent persons in family medicine and geriatrics. I would like to welcome Dr. Danya ma'am. She is a consultant family medicine and geriatrics at Kochi. She is the past president of FPA Kerala chapter. Welcome, ma'am, to this meeting. And Dr. Atul Vyas is a colleague of mine working in the department. He completed his MD Geriatrics from AIMS, Delhi, and is currently working as registrar in Department of Geriatrics at KIMSL Trivandrum. I would like to welcome Dr. Atul Vyas to this meeting. So, handing over to Dr. Danya ma'am and Dr. Atul to proceed with the meeting. Over to the chairpersons.
Thank you, Vishnu. Am I audible?
Yes, ma'am.
Yeah. Very good evening to one and all. It's a very important and relevant topic pertaining to our family physicians. As we all know, we've been seeing a lot of elderly patients in our OP as well as at home care settings. I think for us, it will be more of home care settings. We see a lot of geriatric patients and we need to assess them in a detailed way. So comprehensive geriatric assessment is very important, and it actually works on few important points like, the patients usually present atypically, and the disease may be multifactorial. And sometimes, the problems may not actually need some kind of a treatment or a management. And most importantly, polypharmacy, which is, and the adverse drug events, which is very commonly seen in these patients. So without taking much of time, I would like to invite Dr. Aishwarya to deliver her talk on CGA. I think she will be touching on important points like what are the basic tools which we use usually in our OP as well as home care settings. And she'll be explaining each one of them. So moving to and handing over the space to Dr. Aishwarya for her talk. Thank you.
Thank you, madam. Am I audible? Can you hear me?
Yes, you are audible. Yes, you are audible.
Okay, so I'll be sharing the screen now. Is it visible?
Yes, it is visible.
Okay, fine.
Yeah.
Okay.
You can proceed.
Okay. Thank you. I would like to thank AFPI Kerala chapter for this opportunity. So let's start. So today we will be talking about the Comprehensive Geriatric Assessment, or CGA. That's what we call it in short. So what is the definition of CGA? CGA, or Comprehensive Geriatric Assessment, is defined as a multidisciplinary diagnostic and treatment process that identifies medical, psychosocial, and functional capabilities of an older adult in order to develop a coordinated plan to maximize overall health with aging. So that means it is actually a multi-dimensional and multidisciplinary procedure where we identify the risk factors, we diagnose, and then we initiate treatment. And the main aim of this is to actually improve the overall well-being of the patient. So the healthcare of an older adult extends beyond the traditional management of medical illness. So when a patient comes to us with a symptom or a disease, it is not just the disease that we are treating. We are treating the patient. We are treating the different factors related to the patient. So this is actually a very holistic approach. And it requires evaluation of multiple issues like physical, cognitive, affective, social, financial, environmental, and spiritual components that influence an older adult's health. So CGA is based on the premise that a systemic evaluation of the frail older persons by a team of healthcare professionals may identify a variety of treatable health problems and lead to better outcomes. The purpose of the assessment is to plan and carry out a holistic plan for treatment, rehabilitation, support, and long-term follow-up. So it is based on the following principle that the older person is central to the process. That is very important. Then he or she must receive an assessment in a timely and effective manner and should be in accordance with his or her felt needs. That is also very important. We have to see what the patient or the caregiver actually wants. And this is a standardized assessment. So why CGA? Why do we require a comprehensive geriatric assessment? We know that the aging population is increasing in India. As per records, it is around 30 million population in India are in the geriatric age group, and it is expected to rise by 20% by the time we reach 2050. So people are living longer, the life expectancy is increased, so the disabilities have also increased. Along with them, the limitations and decreased quality of living is also an issue. So comprehensive geriatric assessment will lead to a systematic evaluation that will lead to diagnosis and addressal of health problems, which will in turn lead to better outcomes. Now, different components of CGA. From this diagram, we see that there are a lot of components and everything is focused on the functional status of the individual or the older person. So, and all these components are interlinked. There is medical component, affective, social support, spirituality, environmental, cognitive, and economical domains that are the components of CGA. Now, before moving ahead, I would like to touch upon different problems the older adult faces, and these come under the geriatric syndromes. They include falls, incontinence, dementia, delirium, depression, spontaneous bone fractures, insomnia, neglect and abuse, weight loss and muscle loss. These are the common problems that the older population encounter. So the different names have been given, like the geriatric giants, which include the immobility, instability, incontinence, impaired intellect and memory. And it is also said like 4Ds, dementia, delirium, depression, cognitive decline. So all these are the problems faced by the geriatric population. And before moving further, I would just like to clarify between frailty, disability, and multimorbidity. We usually use the term frail, like that individual, that adult is a frail individual. But actually, what is frailty? Frailty is actually defined as the loss of an individual's ability to withstand minor stresses because the reserve function of several organ systems are so severely reduced that even a trivial illness or an adverse drug reaction may result in organ failure and death. That is, the patient is frail means that a minor stress, like maybe an infection or a sepsis or something like that, can actually push the patient to the edge, that the patient may not be able to withstand even the minor stresses. So these people are called frail older adult, and there is increased vulnerability to loss of function. So frailty in itself is a big topic, and I'm not going in detail in that. I just want to say that there are 5 indicators of frailty. That is weakness, slow walking speed, low physical activity, self-reported exhaustion, and unintentional weight loss. These 5 indicators can indicate that the patient is frail. And there are different classifying methods and all. I'm not going in detail to those. And then what is disability? Disability indicates loss of function. It can arise from a single pathological event, for example, stroke, in an otherwise healthy individual. That is, a person may be otherwise healthy, but he had a stroke and he has residual weakness, and after recovery, but his function is largely stable. So he may not be a frail adult. He may have disability, but there may not be frailty. But when frailty and disability coexist, the function will deteriorate rapidly, even with the minor illness. So that is a very dangerous combination. And next is multimorbidity. Multimorbidity means the number of diagnoses. A patient can have so many diagnoses, like he might have diabetes, hypertension, and so many other diagnoses. But that doesn't mean that he is frail or he has disability. But multimorbidity has got its own problems, like there are different issues associated with multimorbidity, as we all know. So that was the difference between these 3 terms. Now, coming back to our topic proper, CGA. So when does an older adult require CGA? This is required when there is acute illness associated with significant change in the person's functional status. A frail patient is experiencing 2 or more geriatric syndromes. The individual has major illness. There are recurrent hospitalizations in the past or are predicted in the future. And one is considering a change of living status from an independent living to an assisted care facility. There is a planned surgery in cancer patients prior to chemotherapy. And there are psychosocial issues relating to lack of finances or social isolation. In these situations, we require a comprehensive geriatric assessment. And CGA is not done when there is a terminal illness, because we may not have much to do in this situation. When there is severe dementia, when there is complete functional dependence, and when placement in a care facility is inevitable, and the older person is completely functional without any comorbidities. Now, how is this done? This is usually done with different standardized tools designed to identify the presence and severity of a problem or a need. The measures for effective treatment and rehabilitation should also be available. Now, who comprises the team? There is an assessment team for this. It is, as I already said in the beginning, it is an interdisciplinary team. The core team members include a physician. It can be a family physician or a primary care physician, a geriatrician, a specialist nurse, and a social worker. These 3 people form the core team. And then there is the extended team with appropriate therapists, like the physical therapist or the occupational therapist. So who is an occupational therapist? Occupational therapists are healthcare workers who work with people who have disabilities that prevent them from participating in their normal daily activities or in their social activities. So they help in reinitiating these patients to it and help. They look after the home environment of the patient, home safety, etc. These are all done by the occupational therapist. Then there are the nutritionist, pharmacist, psychiatrist, psychologist, dentist, speech and language therapist, podiatrist, etc. And most importantly, the older person and family, their carers or friends, also augment the findings of the core team, and they are also included in this assessment team. And increasingly in the West now, CGA programs are moving towards a more virtual team concept in which members are included as needed. It is conducted online or via different locations on different days, and team communication is completed via telephone or through electronic health records. Now, where do we conduct the assessment? The several meta-analysis of randomized control trials have evaluated 5 models of CGA. They include home geriatric assessment, acute care units, post-hospital discharge, during OP consultation and IP consultation. And these meta-analysis have found that the home geriatric assessment and acute care units provide more detailed information for and help in betterment of the patient and their well-being. So these two are most importantly considered. Home geriatric assessment and acute care units are the beneficial places where it is good to conduct a CGA. Now, how do we conduct the assessment? There are different steps. First, we gather the data gathering. Then we discuss among the team members, which includes the patient and the caregiver. Then we develop a treatment plan. We implement this plan and we monitor response to the treatment plan. And we revisit the treatment plan. This is very important. First, we gather data. Then we discuss or brainstorm among ourselves and the patient and caregiver. Then we develop a plan. We implement the plan. We monitor the response to the treatment. And we keep revisiting and reviewing the plan and making changes accordingly. So one good thing is that most of the early CGA programs were actually focused on restorative or rehabilitative goals. That is, they were more in favor of tertiary prevention. But the many newer programs are aimed at primary and secondary prevention, which is a good thing and which will help in improving the quality of life of the older adults. So that this is how we conduct the assessment. Now, there are various assessment tools. Like the potentially available information actually may seem very overwhelming, but there are different formal assessment tools and shortcuts that can reduce this burden. So one easy thing that we can do is to give a pre-visit questionnaire to the patient or a caregiver. That can be done either via email or we can, before consulting us in the waiting area, this can be given to the patients. This will help us in gaining general history, past medical history, their medication history, social history, and other information specific to CGA, like the ability to perform functional tasks and need for assistance, fall history, urinary and fecal incontinence, pain history, source of social support like family and friends, symptoms of depression, and vision and hearing difficulties. These are all specific to CGA and these can be assessed via a pre-visit questionnaire to the patient. Now coming to another important topic, domains and items to be assessed. I'll be discussing about the 5 major domains. One is medical domain. Then there is mental health, functional capacity, social circumstances, and environment. So in medical domain, we ask or assess the comorbid conditions and the disease severity. Then we have to medication review should be done at each visit and we have to address polypharmacy. I'll be talking about all this in detail in the coming slides. Then we look at the dentition, nutritional status, incontinence, both urinary and fecal, vision and hearing, and problem list has to be updated at each visit. That is the medical domain. And mental health domain involves cognition, mood and anxiety, and spirituality. Spirituality is very important to an older adult and we have to ask regarding that, whether there has been any change in their spirituality and what is helping them cope up, etc. Or these are spirituality has a very important role to play in the life of the older adult. Now, functional capacity. Functional capacity is assessed by the basic ADLs, that is the activities of daily living. I'll talk in detail about it later. Then history of fall or fear of fall, gait and balance, activity and exercise status, and instrumental activities of daily living. These are the items assessed in functional capacity. And in social circumstances are assessed by looking at the availability of informal support from family and friends, finances. Then we have to look for signs of elder abuse, mistreatment, and carer burden and carer burnout has also to be should also be addressed. And environment domain should be assessed by their home facility, their home safety, transport facilities, and accessibility to medical aid. This is a diagram that I took from Davidson. We can see the domains include function and ability, disease severity and comorbidity, mental health and cognition, and support networks and needs. So a little bit in detail about these domains and how to assess. So medical domain is assessed by taking a detailed history. Like in any case, we take a detailed history. We do a physical examination, system examination. Then we take a family history. We also take a list of the current health providers and list of the risk factors and conditions for which preventive interventions are being applied. We should also take orthostatic BP because of falls is a big geriatric syndrome. And vision and hearing, these are assessed by our usual Snellen's chart, and hearing can be assessed by Rene's test, Weber's test, etc., or by specialist. Then pain should be assessed. Pain is actually an underrated symptom, or it is not talked about much in this age group, but pain is actually a very big problem, and through proper management it can be managed, and pain does have a significant impact on the quality of life of the older individual. So pain should be, we should ask about pain. Then incontinence. For incontinence, if there is a history, we can do a PR examination or a pervaginal examination. We can rule out urinary tract infection. The nutrition can be assessed through the 24-hour recall diet, BMI, ability to plan and prepare meals, etc. Then we can screen for depression, and then dental examination to detect tooth decay or poorly fitting dentures and appropriate referrals. So that is how we assess the medical domain. Now, coming to functional status. This involves two main things, that is activities of daily living and instrumental activities of daily living. ADLs is associated with self-care. That is the things that are required for the self-care of the individual, like bathing, dressing, toileting, maintaining continence, grooming, feeding, transferring. All these form the activities of daily living. And what is instrumental activities of daily living? That is the ability to maintain an independent household, which requires shopping for groceries, driving or using public transport, using gadgets, electronic devices, smartphones, housework, doing home repairs, laundry, taking medications, and handling finances. These form the instrumental activities of daily living. There is another thing called advanced activities of daily living, but that varies from person to person. It includes the ability of the individual to fulfill his societal role or family role. That differs from person to person, then that is called as advanced ADL. So to assess the functional status, there is a scoring system called the Vulnerable Elder Survey, or VES-13. It has got various domains like age, self-rated health, ADL, IADL, difficulty in special activities like kneeling, bending, stooping, performance of housework, reaching out and lifting upper extremities above the shoulder, lifting and carrying weight, walking, writing or handling and grasping small objects. All these are domains and they have their corresponding scores. And we can ask the patient and we can score it, and a score more than 3 suggests that it's a vulnerable older adult. Now, gait speed assessment. That is also an important part of the functional assessment because it predicts the functional decline. It identifies those who require further assessment as it can lead to falls. So just in brief, a gait speed of more than 1 meter per second indicates that there is a better survival rate in community developing older adults. A speed of less than 0.8 meter per second is associated with limited capacity for community ambulation, and less than 0.4 meter per second identifies those with an inability to meet basic ADLs. Means just understand that gait speed assessment predicts functional decline and we have to assess it. Now, faults and imbalances. This should be integrated in history and evaluation always because it is a big problem for the elderly older adult, and we have to take a detailed history and inquire about faults and imbalances. So an easy way would be when you see a patient above 65 years, just ask these 3 questions. Have you fallen in the past year? Do you feel unsteady when standing or walking? And do you worry about falling? This is just 3 questions. And if the answer is yes to any of these key screening questions, they are at increased risk for falling and they require further assessment, a detailed assessment to identify the cause of falls and help in prevention. Now, the another domain is cognition. Cognition has got various domains like learning, memory, language, attention, judgment, reasoning, speed of processing. We all know about that. Then executive functions like decision-making, planning, working memory, responding to feedback, inhibition, task initiation, organization, and self-regulation. So in these patients, we have to take a past history of head injury or stroke, and a family history of dementia should also be elicited. And we should ask about the educational status of these patients. And for cognitive screening, there are various screening tools available. Some of the examples I have noted here, like the MOCA, Montreal Cognitive Assessment, MMSE, Mini Mental State Examination, Frontal Assessment Battery, and the RUD as the Rowland Universal Dementia Assessment Scale. All these are screening tools to assess the cognition of the patient. And accordingly, we can classify into mild, moderate, and severe. And when we talk about cognition, we have to say about dementia. We all know it is a disease that attacks brain and destroys brain cells and functioning. That is, it is a neurodegeneration. It is an umbrella term. There are many kinds of dementia like Alzheimer's dementia, Lewy body dementia, etc. This has got problems with memory, thinking, language, and behavior. And the sad thing is that it is progressive and irreversible. And it is not at all a normal part of aging. And sadly, currently there is no cure. There are only measures and drugs to delay the progression of dementia. And so, in an individual with dementia, if there is a sudden change in their behavior or a sudden decline in their cognition, it means they have delirium. Delirium is an acute situation where a small stress like infection or an electrolyte imbalance or a metabolic imbalance can lead to fluctuating cognitive decline. And if the cause is addressed, then the situation is reversible. So we need to know about delirium also. Now, the another domain is the mood disorders. So late life depression remains underdiagnosed and inadequately treated. It may not have typical signs and symptoms, and it will be difficult to assess in a person, especially in a person with cognitive impairment. So a simple 2-question screener can be used. One is, we can ask them whether during the past month, have you been bothered by feeling down, depressed, or hopeless? And during the past month, have you been bothered by little interest or pleasure in doing things? If there is a positive screen, then this can be supplemented by other screening tools like the Geriatric Depression Scale. That is also a scoring system which through which we can know the severity of the depression. Now, another major problem that these patients face is polypharmacy. We all know that they may have multiple diseases. They may be taking multiple medications from multiple care providers. So Beer's criteria is a criteria that can help us in dealing with polypharmacy. It is based on the fact that older adults respond differently than younger adults to medications due to changes in drug absorption, distribution, metabolism, and elimination. So they can have more or less sensitivity to these drugs. So these changes are unpredictable, and there is an increased risk for drug-to-drug interactions and adverse drug reactions. So Beer's criteria are a unique set of evidence-based recommendations which are tailored specifically for older adults in all care settings except hospice and palliative care. So it is a evidence-based recommendations. This will involve a list of potentially inappropriate medications, and this will provide guidance on how to optimize medication selection in older adults. So that is the importance of Beer's criteria. What we can do is we can ask the patient to bring all their medication, both prescription medications and non-prescription, like over-the-counter medications. And discrepancies between what is documented in the medical record and what the patient is actually taking must be reconciled. Then we can try to de-prescribe safely. So we first divide the medication, that we divide it into 2 parts. Those medications that help in relieving symptoms like diuretics in cardiac failure or analgesics for pain, and those that are not involved in relieving symptoms but are aimed to decrease the long-term poor health outcomes like statins, BP medications, then vitamin supplements, etc. Then we have to ask, or we have to think about these questions. Are they still needed? Are they tolerated well? Are they being taken at all or at the right time? Is there a risk of overdose? Can they be decreased or consolidated or de-prescribed safely? These things we have to think about. Then who might I need to inform of these changes? Whether I should inform to their cardiologist, endocrinologist, neurologist, etc. So that was about polypharmacy. Now the next domain is social support. A brief screen of social support includes taking a social history and determining who would be available if the patient becomes ill. So early identification of problems with social support can help in planning and timely development of resource referrals. Now, environment, home safety evaluation and possible solutions should be found. We have to inquire and we have to check the home safety. There are different solutions like we can install handbars or rails, especially in the toilet for when and anti-slipping mats. And we should tell them that the room should be clutter-free. And even for patients with low vision, we can have demarcation, like we can use fluorescent markers or stickers like that, and which can help in the patient in demarcating like the steps while going downstairs or upstairs, or different rooms, etc. So there are various measures to ensure a safe home, and the occupational therapist usually looks into all these things. And additional components, as I already mentioned, we have to look into their nutrition, whether there are any weight changes, incontinence, sexual function. Incontinence and sexual function, actually, we have to inquire in detail, because the older adult may think that it is very common in the old age, and they may be hesitant to share it with us. So we have to inquire about this, because sometimes the solutions to these problems may be very simple. So we have to inquire about these two things, that is incontinence and sexual function, then vision and hearing assessment, dentition, living situation, purpose in life, and spirituality. Next important domain is the caregiver support. We have to identify caregiver burnout, and if present, we have to refer for additional caregiving services or counseling or support groups. Now, another important aspect is the elder mistreatment. Neglect and abuse of the elderly can be of different types. It can be physical, emotional, neglect, financial, sexual, and abandonment. So the signs include the patient may appear to be depressed, confused, and withdrawn. He or she may be isolated from family and friends. There may be unexplained bruises, burns, and scars. The person might appear very dirty, not well-groomed, underfed, over-medicated or under-medicated, or not receiving care for their medical problems. They may appear dehydrated. They may have bed sores or other preventable conditions. And the necessary aids like spectacles or the hearing aid or the walking cane, these may be missing. And there can be recent change in banking or spending patterns also. All this indicate towards elder mistreatment, and it should be inquired in detail. Now, advanced care preferences. This is in the context of future deterioration in health status. Acceptable treatments, procedures, and determination of surrogates to make decisions, also called healthcare proxy, is determined by the patient when the patient is not in a not in a position to make decisions. The patient itself can assign such healthcare proxy. So advanced care directives help guide therapy if a patient is unable to speak for himself or herself, and are vital to caring optimally for the geriatric. Now, goals of care. Choices must be made about what outcomes are most important for the patients and their families. Example, what they require may be attaining their previous functional status, maybe attending their family functions, visiting their grandchildren, or living at home, maintaining social activities, etc. So we have to ask what is important to the patient and their family. Now, what are the benefits of CGA? Frail older people benefit the most. The aim is to maximize chance of recovery, function, and quality of life, and assessment is directed to meet their particular needs. It is, as already said, it is patient-centric goal. The clinician can spend shorter period of time reviewing the results of the screens done by the trained members of the team, and this will enable the clinician to prioritize which domain requires urgent attention and intervention. And comprehensive geriatric assessment results in improved detection and documentation of the geriatric problems. So these are the benefits of CGA. So I'll just brief up. We talked about what is CGA. Definition. It is actually a misnomer, because it is not just pure assessment. It is identifying and taking necessary actions to improve the quality of life of the patient. That is the main thing, and patient preference is also very important. And we discussed about different domains of assessment, how we can assess these domains like medical, functional, environmental, social, mental, mood disorders, etc. All this has to be assessed. And then we have to make we have to gather data, make a comprehensive plan, and review the plan. So that is in brief about the comprehensive geriatric assessment. So proceeding further, I'll give a few examples. This is a case study. Mrs. S is an 85-year-old woman. She's a widow living at home by herself. She fell down the stairs 1 week ago. Since her fall, she walks slowly while holding on to the furniture, does not leave her apartment, is not eating well, and is calling her daughter anxiously several times a day. Her daughter has brought her to your clinic for evaluation. So how should you evaluate this patient? At the clinic, her physical examination is normal. Timed up and go test. This is a test to assess falls. Normally, a patient, when the patient is asked to get up and go, it takes only less than 12 seconds. But here, the patient takes 45 seconds. There is difficulty in rising out of the chair. She cannot advance further without holding onto the furniture. The activities of daily living score is 5 out of 7, and she needs help with toileting and eating. The instrumental activities of daily living is 10 out of 14. There are problems with finances. Her cognition score is 20 out of 30. There is short-term memory loss, visual spatial disorientation, problems with calculation. Means that suggests there is early signs of dementia. No wonder she is having problems with finances. And the depression score says that it is 8 out of 15. And her social domain, when we assess that, we find that she has one daughter who is 55 years old, caring for her husband with lung cancer. And this daughter can take her home on weekends. Also, a niece is available twice a week. Her monthly income comes around 5,600 rupees. So this was the history of the patient. So what is the impression? Impression is post-fall syndrome, that is fear of falling and fear of loss of independence. Then there is moderate depression, moderate cognitive decline, and she is at risk for malnourishment because she is not eating well. So this is the impression that we get from assessing the patient. Now we make a plan. The plan can include physiotherapy at home. An occupational therapist can visit the home for home safety audit. Antidepressants can be started. We have to start low and go slow. And in-home caregiver can be appointed, for helping with toileting, housekeeping, meal preparation, and can help in eating. So a home caregiver is essential in this case. And then we can refer the patient to available support groups like those facing loneliness. We can ask her friends to visit, etc. So this is another aspect, 4M's framework. That is what matters: medication, mentation, and mobility. This is the same thing which I already explained, like what matters. We have to know and align care with each older adult's specific health outcome goals and care preferences. And it is not limited to end-of-life care, and it is spread across settings of care. Then medication, which medication is necessary, use age-friendly medication, use the BS criteria. Then mentation, we have to prevent, identify, treat, and manage dementia, depression, delirium across settings of care. Then we have to assess mobility and help the adults move safely in their home and to maintain their day-to-day functions. So all these come under the 4M's framework. Now, another example, this is just a little bit complicated patient. She's an 87-year-old woman living with her husband at home. She has increased frailty and slow decline in function and cognition, and she has multiple comorbidities. She sees about 6 specialists, and there are frequent review visits, and at least 10 medications are there to which she is compliant. She has been needing increasing support from the family. Supports include her husband, who is more robust. He still drives, handles finances, meals, shopping, and supervises her shower and medication. She has 3 daughters, all live nearby and come to help when needed. Equipments include bed rails, and there is no backup plan if husband becomes unwell. It is assumed that the daughters may help more in such situation. Then she has a big list of comorbidities like hypertension. She is a CA breast patient, post-lumpectomy and radiation and hormone treatment, hyperthyroidism, atrial fibrillation, vertebral crush fracture, degenerative OA spine, reflux disease, mild CKD, and cataract for which surgery is planned. Now, geriatric syndromes include cognitive impairment, falls, osteoporosis, urinary incontinence, maybe due to UTI, and pain is present, but she's not on any analgesic or any physical therapy. On physical examination, her weight is 48 kg. She appears clean. She's engaged in history, but she's not informative. BP is 120 by 80 on sitting and 100 by 70 while standing. Vision and hearing are poor. RUDAS. RUDAS is a cognitive assessment scale. That scoring is around 13 out of 30. She has to sit to stand using hands, and when mobilized with help, she is very unsteady. So the risk of falls is also very high. System examination, systemic murmur is present, JVP is not raised, irregular heartbeats, chest is clear, dry mouth, no abdominal scars. She is wearing an adult diaper which is wet. Lower limbs are dry, no edema, osteoarthritis of the knee is present, bilateral sensations are poor. Then polypharmacy. She has taken, as I told you, she's taking multiple drugs, and we can divide it into drugs which make her feel better, like omeprazole and eye drops. Then those drugs which which are helpful in preventing disease progression include apixaban, folic acid, iron supplement, metformin, calcium, and vitamin D3. So this is how we classify her drugs. Now, what is the diagnosis and plan? So the diagnosis is vascular dementia, and we have to educate the family and the caregiver about the progression and trajectory of the disease, the impact on behavior and mobility. And we have to tell them what to do if acute change in behavior occurs. That is when there is delirium, we have to tell them what to do. There may be a cause behind this delirium, that is acute change in behavior. They have to identify it and bring it to the notice of the doctor. Then pain and falls. For that, we can advise on physiotherapy and explain the role of analgesia and give analgesics, mobility aids, and evaluation of what causes the falls, maybe peripheral neuropathy. Then urinary incontinence, treatment of urinary tract infection, then identifying nocturnal issues. Is it a medication side effect? Is there constipation? Then overall prognosis also we have to explain, like we don't know for sure, maybe unlikely to be 5 years. There will be slow deterioration of mobility and organ failure, and slow progression of dementia to bedbound stage can happen, and with associated complications like aspiration. And one bad sepsis or one bad fall may not be good for the patient. And if those things happen, are there any advanced care directives? What should be the plan? We have to ask and we have to prepare a plan accordingly. And we have to ask the family to follow up, ask the family to come, ask them to contact you if the patient ends up in emergency department or in other hospitals, or when they are not sure what to do. And we can also offer to look after the spouse. So that was the 2 examples. And just a few words about role of CGA in hip fracture. It is very common. CGA will identify the modifiable medical problems, help in reduction of polypharmacy, evaluates the risk for delirium. Like we will already be knowing about a baseline cognitive status. And we can take adequate, appropriate analgesia, and choice of anesthetic can also be assessed and determined. Then post-op early mobilization, hydration, nutrition, discharge plans. All this, if we carefully plan, then the quality of life will improve significantly for the patient even after the surgery. Then we should address the cause of this hip fracture. Falls risk we have to assess. We can assess the bone health assessment using DEXA scan and management as required. Now, pre-operative CGA. We all know the rate of adverse post-op outcomes will increase with age, and optimization of outcomes by identifying medical problems is done by CGA. There will be baseline data on medical issues, cognition, falls, functional ability, continence, and carer roles. Then this will help in reduction of post-op complications and proactive care of the older people undergoing surgery. So this will eventually lead to reduced length of stay, and once the patient is discharged, the patient can more or less function properly. Even in cancer treatment, CGA is important in determining the cancer treatment options, whether the patient will be able to withstand the treatment, what are the comorbidities of the patient. We can plan a treatment plan accordingly and look for adherence, and quality of life should also be assessed. So a primary goal of CGA is to evaluate the older person's ability to tolerate and respond to therapy and provide interventions to potentially improve the outcome. So I would like to conclude this presentation by saying that you do not heal old age. You protect it, you promote it, and you extend it. Thank you for your patient listening.
Thank you, Aishwarya, for that elaborate and informative session. Over to Dr. Atul.
Oh, yes, it was a very crisp, clear, and concise presentation. And comprehensive geriatric assessment, many people think that it is just applying a bunch of different scales, just throwing a lot of scales into the patient. Actually, it's much more than that. And as she has rightly pointed out, it plays a great role in the planning for the treatment, whether to decide on the treatment and to monitor the outcome. One of the common mistakes the physician makes while doing the comprehensive geriatric assessment is that most of us, almost all of us rarely care to follow up the patient, whether the intervention you have given actually works or not. Another potential area of error is lack of communication between the patient and the caregivers. And there are also instances where one can totally ignore the outcome of your treatment the outcome, the adverse effects of the treatment, and convey incorrectly to the patient and caregivers. A common example is once someone starts a patient on Syndopa, Parkinsonism patient who is on Syndopa, many a times the doctors forget to tell that one of the side effects of Syndopa can lead to behavioral abnormalities, can cause psychosis sometimes, and behavioral disturbances. But the patient ends up thinking that the doctor has done more harm than good to the patient. It's simple miscommunication. So again, all this can be controlled to a great extent by comprehensive geriatric assessment. And of course, it's very difficult to go into in depth of each of the components. For example, even just simple cognitive screening, you can do a mini cog or MMSC, and before doing a mini cog or MMSC, you have to first ask the patient, do you feel sad? Are you depressed? Because most of the time the dementia which you come across can also be pseudo dementia. The patient might be depressed or having hypothyroidism or having low vitamin D. So that there is you have a different panel if any of the screening test for cognition becomes positive. So like that, each and every one of the components has a separate panel, a separate algorithm to approach. For example, what happens when the patient returns positive for fall risk? So all those evaluation, the starting point is comprehensive geriatric assessment. So rather than just subjecting the patient through a bunch of different tests and examination, comprehensive geriatric assessment really helps channel, even in a resource limited setup, it can easily be administered. It's almost cheap and it's free actually. So you're doing a great help to the patient by reducing their exposure to unnecessary treatments and investigations. And as she rightly pointed out, we do comprehensive genetic assessment for hip fracture. Actually, in the hospital where I work, we have a fracture liaison service where an elderly who has suffered a hip fracture, within 24 hours is seen by both a geriatrician as well as an endocrinologist, and baseline DEXA scan is done, and subsequently they're followed up. So yes, such systems are in place, and you have to seek the help of other disciplines as well, especially the surgery. Pre and post-op delirium is a very common occurrence, and many times you see the other specialty, especially the surgeon. There's a tendency for surgeons to prescribe benzodiazepines for delirium, which is something you absolutely should not do. I have come across, most of the consultations I get, almost 90% of the consultations I get consist of inappropriate prescription. So you of course, there is this Beers criteria, you have start-stop criteria. So all those tools you have at your disposal to find out potentially inappropriate medications and drug interactions. Even very, very simple thing which I come across is people, the patients are subject to unnecessary investigation just because someone has prescribed a dose of antihypertensive a little too much. So such common things can actually occur. It can be as simple as changing the timing of the antihypertensive, but see, that comes again back to comprehensive geriatric assessment. So everything you can trace back to comprehensive geriatric assessment. And anyways, thank you, Dr. Aishwarya, for that wonderful presentation. Even I myself have been I'm wonderstruck by how clearly you have mentioned the concepts and how briefly you have mentioned it. To go into detail with comprehensive geriatric assessment, of course, it's beyond the scope of the discussion. However, I would also like to add that if someone is looking for a rapid screening, for example, we have the rapid geriatric assessment (RGA) screening. This consists of 4 items. One of them being SNAC, Frail scale, Sarkov scale, and rapid geriatric screen. So we have such an entity as well, and most of the times when the patient comes to you in the OP, if you want to do a proper assessment, you can just do quick assessment of each of the domains by asking a few questions. For example, you can assess the functionality by a brief interview, like what all they do in their home. Are they able to maintain the finances? Are they able to go to the washroom? Are they able to dress themselves? Are they able to feed themselves? So questions like that it takes around 5 minutes. So just by it takes practice actually. So all these domains you can actually touch upon. The meditation, the environment, the multi-complexity, multi-mobility, the medications. I mean, again, even though geriatric assessment is comprehensive, you can still touch upon the various by knowing what all domains exist. You can still touch upon those domains, and it will hardly take about 5 minutes. That's all. So, anyways, thank you, Dr. Aishwarya, again. Okay.
And we have one question in the chat box. What is the protocol for CGA in a primary care setting? Dr. Aishwarya or Dr. Atul, can you just enlighten? Is there anything different or how we can implement in a primary care setting?
Doctor, as I already mentioned, is actually a multidisciplinary thing that many specialists or healthcare professionals are required for actual assessment. But a primary care physician sometimes may have to take up the role of all these people. And to our capacity, whatever can be done, as the steps are all same only. We have to gather data, we have to assess their situation, make a treatment plan. If the steps are all same, as I already mentioned before. But sometimes we may have to take up the role of all these people, which is very difficult, and sometimes it may not be practical also. Dr. Atul, what is your view on this?
Yeah, so for someone in a primary care setting, I would say that you start with, screening for the geriatric syndromes. Screening for geriatric syndromes is very simple. You just ask if they're having trouble with their memory, if they're having any episodes where they feel, lonely or sad, depression. And you can ask for any question, history of incontinence, difficulty in movement. These 4 questions cover most of the domains actually, whether they're having trouble food eating. Simple questions about the functional status and geriatric syndromes will cover most of the areas in the comprehensive geriatric assessment. It hardly takes around 2-3 minutes. That's all. And that's one thing you can do in a primary care setting. And the other approaches you can do in you see which all areas means which all disease the patient has. For example, someone is having CAD, let's say. So you can probably think about what are the consequences of CAD. The patient might be having trouble moving, or they're having shortness of breath. So related to that, you can keep on inquiring to the domains, how much of their functionality has been limited by that. So obviously, it comes down to if you want to do it very quickly, just inquire about the geriatric syndromes. That's all. Even for incontinence, 3 questions you can ask. It's called 3I questionnaire or 3IQ questionnaire for women, and for males you can ask 7 questions. It's called AU7 questionnaire. So just geriatric syndromes you can start with. It's a good start for geriatric assessment in a primary care setting. That's what I'd say in my experience.
May I?
Yeah.
Just a point to add on. We would already be dealing with these kind of patients, but these tools are actually to help us keep in our mind that certain points have to be we have to go through a pathway. But as family physicians, I think we should have, if you're a private practitioner or a primary care level provider, you can actually make a protocol of yourself, a few points which you can actually add on to, and you can keep on exercising it as you keep on seeing patients. You need not do these kind of assessments elaborately. That's what I meant.
Thank you for the inputs. Do we have any more questions? I don't find any in the chat box. So this was a very important topic in clinical practice as well as for the PGs. It is very important for your exam perspective also. Every exam you are going to encounter questions in this perspective of geriatrics, and whether it be polypharmacy or falls or geriatric assessment or elder maltreatment, everything comes from the clinical perspective as well as exam perspective. So I would like to call upon Indu ma'am, for your closing remarks, if you are available. So I think she's not here. So I would like to thank Dr. Aishwarya for taking up this responsibility of doing the presentation for the clinical meet series of on the topic of comprehensive geriatric assessment and delivering a wonderful lecture and very concise at this time, covering all the important areas that is required for a clinical practice in primary care or a family medicine setting. And I would like to thank Dr. Danya ma'am and Dr. Atul for willingly accepting our invitation to be the chair for the session and giving your invaluable inputs and insights on the topic. And I would like to thank all the participants. We had around 100 participants for this session. So I would like to thank all the participants who have joined for the session and also the executive members of FPA Kerala for having given us the opportunity to go ahead with this program. Thank you. Have a good day.